So today we'll discuss how to correct the hypokalemia in ICU. Basically, we had this case of 72-year-old female who developed the paralytic ileus. Her abdomen was distended, and after all the series of corrections also by potassium chloride, her potassium levels were not improving. You can see it was 2.6, 2.3. So, and her abdominal girth was increasing. So she was later diagnosed to have a refractory hypokalemia. So how to manage such cases? Firstly, the etiologies of hypokalemia. Here you have to basically focus on the diuretics and laxatives over abuse. So you don't have to use basically loop diuretics or thiazide diuretics. You can use potassium sparing diuretics such as L-diclone, that is spironolactone in such patients. Secondly, what important is there are some antibiotics also which can contribute to hypokalemia. One of the major culprit is cholesterol. So studies have shown that after 7 to 10 days of cholesterol regular therapy, there is a tendency of development of hypokalemia. One more important term is pseudohypokalemia. Basically, myeloleukemias in which the leukocyte levels are extremely high. They can present in IPD or OPD as a pseudohypokalemic patients. This is a vial of potassium chloride, which is regularly used in ICUs. So each injection, each ampule contains like 10 ml of KCL. So 1 ampule has 10 ml of KCL and 1 ml has 2 milliequivalent of KCL per ml. So the final milliequivalent will be 20. So 1 ampule will contain 20 milliequivalent of KCL. So how you have to correct the potassium level? Basically, we use this formula in like early days. So we have to calculate the potassium normal, and it has to be like subtracted to potassium in the patient, and it has to be further multiplied by zero point 0.4 into body weight. So this was the formula which was earlier being used, but it wasn't found to be much effective just because it doesn't increase the potassium reserve of the patient. It only corrected the momentary deficit. So the simple approach is for every drop of 1 millimole per liter, give 100 to 200 milliequivalent of KCL. So the final orders will be injection KCL 5 ampule in 500 ml of NS, which can be given at the rate of 5 to 8 ml per hour. We can also give it in 100 ml or in some cases neat also, but what you have to keep in your mind is whether your patient is getting thrombophlebitis or not. You have to maintain and regularly monitor the thrombophlebitis symptoms. So ideal rate of infusion. Basically, if you are giving KCL from a peripheral line, so you have to give 10 milliequivalent to per hour to 5 milliliter per hour. A maximum you can go from for peripheral line is 20 milliequivalent per hour. If you are giving it from central line, ideally you should give 20 milliequivalent per hour, and maximum you can go for 40 milliequivalent per hour. So interpretation of the low potassium level on the symptomatology. So normal is 3.5 to 5.5. Maximum like patient which will find will be in mild, that is 3 to 3.5, and these patients will be asymptomatic. Between 2.5 to 3 patient may have mild symptoms of ileus. That's why you have to get an X-ray abdomen done in such patients to rule out the early ileus. If you're finding 2.5 to 3 potassium level in your patient with mild gastric distension. CVRT achieved through potassium level is below 2.5, where you can have muscle cramps, weakness, which will be majorly in the ascending limbs, and in ECGs you may have arrhythmias. If the patient comes to you with ventricle uh, arrhythmia, you can also have tortoise de pointes due to low magnesium level. Further, you can have rhabdomyolysis and heart failure. So these are the ECG changes. If your potassium levels are low, then in ECG, first thing foremost what will happen is your T level will start to flatten. It might get reversed also in few cases, and there will be emergence of U wave. Secondly, you may have ventricular tachycardias as well. So how to differentiate between the ventricular tachycardia of hyperkalemia and ventricular tachycardia of hypokalemia? So ventricular tachycardia induced by hypokalemia will have tortoise de pointes in them, whereas ventricular tachycardia due to hyperkalemia will not have tortoise de pointes in them. So key point, it is a very important thing to keep in your mind that the kidneys are responsible for about 90% of daily potassium loss. So if your patient is in refractory hypokalemia, the first and foremost thing you have to rule out whether renal wasting of potassium is occurring or not. So the kidneys have only a limited ability to conserve potassium. With the little to no intake of potassium, the urine will still contain 5 to 20 milliequivalent of potassium per 24 hours. Second important thing is you have to check the magnesium levels as well. Hypomagnesemia results in higher renal wasting of potassium levels. So correct the hypomagnesemia wherever you are finding the low magnesium level in the refractory hypokalemic states. So how to correct hypomagnesemia? Basically what you have to do is you have to load 4 gram of magnesium sulfate, or you can use 2 gram also, to be diluted in 50 or 100 ml of D5 IV to be administered over 1 hour. You can maintain it also if there's a refractory hypomagnesemia as well. So labs to be conducted in hypokalemia, we have to sequentially send the serum potassium levels. We have to also monitor the hypoglycemia and magnesium level. You can send the urine electrolytes, basically urine potassium level and a creatinine level for the kidney functioning assessment. You have to send the acid-base balance, consider the thyroid and adrenal workup if required. So here it is a very important point, that is the adrenal workup. Basically, aldosterone is a hormone which is secreted by the adrenal glands. So if your aldosterone levels are high, so aldosterone are basically culprit for higher rate of potassium excretion through kidneys. So if your aldosterone level are high, then more and more of the potassium wasting will occur via kidney. So you have to, after correcting the potassium level and magnesium level, third thing you have to check is for the sodium level, and the fourth thing you have to check is for your aldosterone level. So normal urine potassium excretion is 50 to 30 milliequivalent per liter. If it is higher than that, then you are in state to diagnose that your patient is having high amount of renal wasting of potassium. You can also send for spot potassium to creatinine ratio. If it is less than 1.5 milliequivalent, then it is a marker of renal potassium wasting. So here, this is the diagram which is depicting this aldosterone thing. If your aldosterone is abnormally increasing, your renal excretion of potassium is also abnormally increasing. So you have to keep in your mind, you have to check the aldosterone functioning as well. So key point before ending the slide, uh, you have to discontinue the over abuse of laxative and diuretics. Preferably, you have to stop the loop diuretics and the thiazide diuretics. Secondly, use potassium sparing diuretics if diuretics are indicated, like spironolactone, also comes with the brand name of aldactone. Third thing is treat the underlying causes such as diarrhea and vomiting. Fourth thing is you have to use the H2 blocker to reduce the nasogastric suction losses of potassium, control the hyperglycemia if glycosuria is present, and last but not the least, if you are getting a patient who is acidotic by primary nature, correct the potassium level first before correcting it by alkali. Just because think like this, if you are getting a patient with metabolic acidosis, the first thing what you will like to do is that the correction of acidotic component by use of soda bicarb or alkali agents. Now what happens is if you are not correcting the potassium first, then in virtue of correcting acidosis by use of alkali, you will uh, enhance the shifting of the extracellular potassium into the intercellular potassium. So while doing so, while correcting the acidosis, you may turn your patient into severe hypokalemia. So make this a ground rule that while managing a case of metabolic acidosis with hypokalemia, correct the hypokalemia first and then correct the metabolic acidosis. Thank you.